Dr. Manjusha Yagla, member of social media team of World Congress Nephrology of International Society of Nephrology. Welcome to the series of pre-Congress interviews on behalf of World Congress of Nephrology 2022. So here we are today interviewing an eminent speaker in nephrology, Dr. Rachael Morton. She is Director of Health Economics and Health Technology Professor at Clinical Trial Center, Sydney. Good morning, Dr. Rachael. How are you?
Good morning. Good morning, Manju. I'm very well, thank you.
Thank you. So what I learned is that your interest is in economics of the medical and health field. So this, as we know, it's a very dry, little boring topic to all the practicing clinicians. What inspired you to go into that topic? About years ahead, at which time nobody had, thought about to go into the economics of the health field as such.
Thank you. Look, that's a great question. And I'd like to try and convince you that it's not boring at all. It's a fascinating subject. Actually, I was, my previous background to economics was working in health and science. And I was really interested in the trade-offs that dialysis patients made, the things that they had to give up in order to extend their life and accept a dialysis treatment. And it was through that I discovered the field of economics is not just about dollars and finance, it's actually the science of choice. And the way we sort of think about that now is how you choose to deploy scarce resources, both at the health system, the policy level, but also at the individual level. So what I saw that, would resonate with a lot of clinicians was patients in a very remote area who had to leave their home, their families, their language groups, move to the capital city, which was the only place where hemodialysis was available, in order to keep on living. And so this incredible trade-off that patients and families made to accept the treatment for end-stage kidney disease was what absolutely fascinated me. And that inspired me to do a PhD in this area and to undertake economic methods like discrete choice analysis. And then through that, obviously, part of the choice is about how do we sustain this very expensive treatment and how do we offer it to everyone who needs it. So that was actually my foray into nephrology research.
Yeah, definitely. Renal economics is going to play a significant role in the management of the kidney disease patients. And it is a crucial issue when we think about the delivery of the kidney care and health services across the globe. And it's much more important in LMIC and LIC. So how do you foresee the integral part of the renal economics in the practice of clinical nephrology?
I think it's a fundamental and critical part, and it's part of the reality of service provision. So not only do we need to provide, machines, consumables, we need trained, skilled personnel in lower middle income countries. And that will be a variety of people, as it is already. It won't always be, a nephrologist and a certificate-based advanced renal nurse and the allied health team. It'll be a combination of health workers. And so the resourcing for the treatment of end-stage kidney disease, whether it be dialysis, transplantation, conservative care, requires all of these, skilled resources. And it's really, the role, I think, of the ISN, which they're doing very well in supporting low and middle income countries in terms of training for different types of personnel. The other thing that is, I think is really important is, understanding the local context. So for some countries, it's extremely important to be able to provide a particular service. For other countries or health systems, the focus might be on patient preferences. But I think when we look to middle-income countries that have set up formal health technology assessment bodies, and an excellent example of that is in Thailand with HITAP, then we start to see the ability for these sort of economic methods to help inform decision making. So what's the benefit? What's the extension of life? What's the increase in quality of life that a health system might get if you were to introduce, for instance, a peritoneal dialysis program?
Right. So you are into lots of clinical trials. I mean, you are heading now the Clinical Trial Center at Sydney. So can you just tell about the current projects? And also, I'm interested to know about your project SWIFT, which you have started about 2 years back. So how is it coming out? So a brief word about, please, Dr. Rachael, yes.
Oh, excellent. Yes, so that's right. I work at the NHMRC Clinical Trials Centre, and we have a kidney division. We also run clinical trials in other related areas. So our methods really are about expanding the use of randomised trials to generate better evidence. And that might be, very small phase 2 trials. It might be very large, pragmatic, registry-based trials. And certainly in kidney disease, we're utilising country clinical quality registries to enrol and randomise and recruit participants, and then evaluate a lot of the standard treatments that have never been evaluated or compared head-to-head with another alternative. So some of the kidney trials include Resolve, which is looking at different concentrations of dialysate solution. We have a couple of other platform design trials that are looking at different methods for symptom management. And then we have SWIFT, which stands for the SWIFT is Symptom Monitoring with Treatment trial. And what this trial is looking at, it's testing a very simple hypothesis, actually, and that is whether the routine use of patient-reported measures, including a specific symptom measure, with feedback of those symptoms to the clinical team and action, can improve patients' health-reported quality of life. And so that's the primary outcome. And we've seen in oncology that the simple act, if you like, of evaluating symptoms and acting upon them and letting the patient sort of, guide the care or say what's important to them, what's bothering them, that in oncology anyway, that has been able to not only improve symptom management and improve quality of life, but it's also improved overall survival. So we'd like to see whether some of those benefits can be translated into a population with a chronic disease. So SWIFT, the pilot study, has completed, and one of the first papers was published in AJKD this week, showing the feasibility and acceptability of patients completing these patient-reported outcome measures, or PROMs, including the IPOS renal, which is a symptom score, on tablets while they're in the haemodialysis centre. And then the feasibility of that information going back to nephrologists, who then provide, best evidence care to manage the symptoms that are bothersome to patients, but also what the patients then do, because they get copies of their reports as well, as do the nurse managers. So conceptually, it's very simple. Operationally, it's actually, takes quite a bit of time, takes quite a bit of unit organisation, but also it's changing the focus of what the initial conversations are in consultations between patients and clinicians. And the idea is that if SWIFT is found, this intervention of symptom monitoring with feedback, if it's found to be effective and cost effective, then the national or the binational registry for Australia and New Zealand, ANSTATA, will implement patient-reported measures and the collection of those and the reporting of those back to all of the contributing centres, which is every single centre in our countries, alongside all of the other biochemical measures that are routinely reported. So that's where it's really changing the paradigm, I guess, of clinical care.
Yeah. How do you foresee the application of similar electronic PROMs in, the patients from LMIC and LIC? Because definitely it's going to be associated with lots of cost. As you said, the patients were given tablets in order to report their outcomes. So, I mean, just a word about the feasibility of such projects in the LMICs.
Yeah, that's a really good question. In countries where mobile phone usage has a high uptake, and there are quite a number of low and middle income countries where mobile phone usage, smartphone usage is actually quite high, then there may be a mechanism for patients reporting how they feel when it suits them. I think if we were to try and fit into the mold of, a satellite hemodialysis unit, with trained staff, particularly additional staff who might help out with research studies, then I doubt that would work in low and middle income countries. But certainly the self-reporting on whatever device is available, and often it's a phone, at a time that is, convenient, or when there are problems, might make it, might make that process feasible. The other thing to keep in mind is what treatments are available if somebody does have, severe or overwhelming pruritus, or, or nausea and vomiting. And so the other difficulty that I would foresee is the input from a multidisciplinary team, a multidisciplinary kidney care team. And in many low and middle income countries, those resources are very, very scarce. So, whether you have a dietitian or a physiotherapist, or a nurse trained in symptom management, for instance, with skills from palliative care, that might be something that is, is lacking in many health systems, as it is actually in some high income countries.
Yes, yeah. Yes, I think it might take a long time. So, last and final question to you. You're going to speak about an interesting topic in the forthcoming World Congress of Nephrology. Would you like to say a few words about that topic?
I'm glad you think it's an interesting topic, because I think it's fascinating. Yeah, so I'm going to talk about, in the advocacy workshop, how to use the language of government policymakers, how to really get your message through about what is good value for money. And when we say good value for money, we're talking about what benefits can you typically get if you, choose to use the country's money or resources in one way rather than another. And I think that is very helpful language to think about concepts like opportunity cost, and also thinking about, scarcity. So how do we make a decision between, should we have a program for prevention, or should we have a program for kidney transplantation? What would be the benefits of this one compared with the benefits of the other? And then providing a value to those benefits. Because that's the sort of language that, government decision makers are using, and the decisions they're grappling with all the time. So my talk really outlines the sort of language you'd use, and the process and approach you would use if you wish to make a case for a particular type of treatment or a model of care. And then the second thing I'm going to talk about is overall affordability. So you can provide some information about what's the best thing to do, what might produce the most benefits, what's the highest value, but then the country or the health system then still has to be able to afford it. So I'll talk about what we call a budget impact analysis, which is also a really useful method to think about in terms of putting your case forward for a particular kidney care or kidney treatment program. So hopefully you'll dial in and listen to the talk.
Yes, I'm sure we'll be interested in joining you for this session, and I'm sure we will learn a lot from you. A final question: what's your message to the practicing nephrologists regarding the renal economics, how to balance it?
My message is to always think about opportunity cost. Whatever you choose to do, there is the cost of not doing something else, and thinking about what you might forego if you choose to do something. Use evidence. Talk to a health economist and find out what your decision makers want to know. What is it that they want to know. And when they give you a question like, what's the value proposition of a new peritoneal dialysis program, you have to be prepared with an answer. So if you can find a friendly health economist, then that can be really useful. But think always about your opportunity cost.
Right. Thank you. Thank you so much, Dr. Rachael, for being with us, and thank you for the time. I'm sure all of us will join for the session and learn so much about the economics and the budget analysis in the World Congress of Nephrology. See you there in the session. Thank you. Thank you so much. Thank you.
Thank you very much, Dr. Yadler. Thank you.